I'll begin. A very warm welcome to all of you today. Hetero has taken this initiative in these challenging times to bring two eminent speakers who are going to discuss about COVID-19 management. We all know that it has been a challenging time. However, the efforts are going on to fight this pandemic, and Hetero has been at the forefront in trying to provide access to therapies in terms of emerging therapies and new therapies which are available to all the patients. We'll begin today's session by an address by Mr. Shubhra, who is the country manager of Myanmar, followed by the speech by two eminent speakers, Dr. N. Kumaraswamy from India, who is going to talk about management of COVID-19 and emerging therapies, and Dr. Mull, who's going to talk about COVID-19 and Myanmar. So before we begin, I would like to introduce our speakers for today. Dr. N. Kumaraswamy. So Dr. N. Kumaraswamy is the Chief and Director of Infectious Disease Medical Center at Voluntary Health Services Hospital in Chennai. He's also the Director and Site Leader for the Chennai Antiviral Research and Treatment Clinical Research Site of US National Institute of Health. He's involved as clinical investigator for several ongoing clinical research projects with University of California, San Diego, Harvard University, Boston, USA, and New South Wales, Sydney, Australia. He comes with over 25 years of experience and has published more than 400 manuscripts. Dr. Kumaraswamy is an advisor and expert panel member for WHO, ARV Treatment Guidelines Committee, and a clinical advisor to Clinton Health Access Initiative. Currently, he is the regional representative for Asia for ACTG or NIH, and he's serving as a member of the COVID-19 National Task Force for Clinical Research and Development. We welcome Dr. N. Kumaraswamy. We have speaker Dr. Mull O from Myanmar. He's a well-experienced clinician with over 20 years of experience. He's done his internal medicine and general medicine from University of Medicine, Mandalay, and he currently holds the position of Associate Professor, Department of Medicine from University of Medicine, Mandalay. We welcome Dr. Mull. So I'd like to invite Mr. Shubhra to give a small address to our audience today. Mr. Shubhra, you're on mute.
Thank you, Dr. Sham. Good evening to everybody. My sincere thanks to both of the honorable speaker, Dr. Kumaraswamy from India and Dr. Mull from Mandalay. I describe myself as Subhra Prakash Bishwas. I am heading the business of Hetero in Myanmar. We are present in Myanmar for last 4 years. We participate to the pharmaceutical business in Myanmar with 38 products in different therapeutical areas, including hepatitis C management, hepatitis B management, neuropsychiatric, cardiovascular, as well gastrointestinal. So this is how we are present across the Myanmar, about 16 headquarters. Currently, we are having about 50 employees with us in different capacities like managers, finance, HR, implementers and all. And directly come to the subject today, COVID-19. We are proud to share that we are one of the first company commercially supplied Remdesivir, our COVID-4, in Myanmar in the Ministry of Health. So at the time of our, we are very proud that we able to supply the medicine to Myanmar and save more lives. So this is how we are present in Myanmar. And I will not take much time because I'm sure it's going to be very informative and interactive session. I directly now hand over to Dr. Sham for the future sessions. Thank you very much. Thank you to everybody.
Thank you, Mr. Shubhra. So thanks. A request to the delegates who are attending today. So if you have any question, you can post your questions in the question box. These will be addressed during the panel discussion. So we'll begin with today's session. I'd request Dr. N. Kumaraswamy to start his session.
Sure. Right. Hi, everyone. Good evening. It'll be a pleasure to speak to you today on the COVID-19 management, what we do here in India and we can discuss how you can also do similar strategies there in your country. I'm going to share my screen. Somebody have to tell me whether you're able to see my screen. Maybe the host, one of the hosts. Can you see my screen, sir?
Yes, yes.
And you can hear me well?
Yes.
Okay. So I'm basically an infectious disease physician and a researcher. A lot of my focus is on HIV, tuberculosis, and hepatitis. And since this pandemic, which started coming in India in late Jan and sometime around March, it really picked up. A lot of our work is on COVID prevention, treatment, and research. Is something what all our life, currently we have been doing in the last 7 to 8 months. I'm going to walk you through initially through some of those pathogenesis. Then from there, I will go into these clinical manifestations. So all of you know that this disease COVID-19 is caused by a coronavirus, which is an RNA virus. We have this coronavirus been present in our environment, which causes a lot of this common cold. So this is typically another coronavirus. Why it is called corona? Because it is called is the electron microscopy picture, where you can see these crown-like structures. So these are the proteins which are very important for the transmission of this virus, as well as causing this pathogenesis. So it looks like a crown. So the name is being given, from that crown as coronavirus. I don't want to explain to this audience how this virus spreads from one another person to another. So we have, different theories, but now the one proved is all mainly a respiratory-borne, virus, which transmitted from one person to another through the aerosols, as well as through the droplets. There are a lot of still research happening whether this virus will also be transmitted through fomics, that is like droplet falling on the surface, or on the raw surface, or the wet surface and dry surface. So at this time, we do not know, but there are studies showing that the virus can be alive, but we do not know whether it is being transmissible to others. Hence, for these reasons, we keep sanitizing all the surface area. At this time, we don't have enough information on this. So, but it's very clear that it transmitted from one person to another through aerosols, droplets. Hence, for these reasons, we need to have a physical distance with people for prevention, as well as to wear the mask in all our settings, not just in the hospital alone, but also even our routine life. It's something what we have to live with in our new normal life situation. As you all know that the first virus, I don't want to bore you with all the epidemiology, which I'm sure you would have seen in media and televisions and newspapers and everything. So I'll quickly go through this. We all know that the virus was first diagnosed in Wuhan in a market where there are a lot of wild meat has been sold. That is in the last week of December. That's what it's called COVID-19, coronavirus disease 2019. So started in China, immediately got into other countries as shown by these light color, pinkish. So within a month, by Jan 30th, where the numbers swelled to 8,000 and the infection spread through the neighboring countries, including my country of China, in Australia, and in the United States, and some parts of Europe, particularly Italy, France, Germany, and Spain, and some of the Scandinavian countries. And soon, by March end, it went to 783,000 patients. By the time I had the opportunity to see one of the first cases in my city of Chennai, sometime in mid-March, there's the first case which we diagnosed in our hospital in Chennai and managed. And by April 30th, the numbers went up to 3.3 million. You can see almost most part of the world is being affected. It spread so quickly. We've never seen any pandemic had spread so quickly in the past. And it went to May 30th, 6.1 million, and June 30th, 10.5 million, and by early July, 11.3. So numbers keeps going. So it's been spreading. There is no doubt on that. So this is something what I have found, from the online media until yesterday. And again, if you browse today, the numbers will be different. So globally, almost around, we have, very large number of people, almost 45 million people is already been infected. And we have got 1 million, deaths been already. It's been very much alarming. Again, if you take in my country, so where you can see it's still, again, the numbers are going up, where we have almost 8 million people out of these 45 million, 8 million India alone, and we have more than 121,000 deaths so far. And we have been seeing in our country anything from 50,000 to 90,000 new cases a day, every day. Again, in my own city of Chennai, we see around 1,000 cases, new cases a day. And in my hospital, almost 10 to 15 new patients every day we have been seeing. And also in my country, in India, where 700 to 900 deaths have been seen every day due to COVID disease. It is really alarming. So I also had an opportunity to browse and get some data from Myanmar. So till yesterday night, 51,000 people been reported and almost 1,200 deaths. And also in your country, you're seeing almost 1,000 new cases a day and deaths more than 20 a day. Don't think that, it's only 1,000 and in India, 50,000. We were like this, a few months back. Suddenly, within a few weeks and months, the numbers went up. So it's a matter of time, because this virus is a respiratory-borne virus, easily spreads. The virus can, spread across very quickly. Hence, you have to be very careful how you have to target your public health program in prevention. And again, as I said, this is a respiratory-borne virus, where this virus is an RNA virus, which has got these corona-like structures, the crown-like structures, we are called the proteins. Particularly, there is a protein called spike protein, which is very important for the virulence and antigenicity of this virus. So this virus enters into the human system either through the nose or through the mouth, through the enterocytes or through the pneumocytes. So this spike protein gets attached to one of these cells, either through the nose or through the mouth, and gets attached to two different receptors, predominantly to ACE2 inhibitor, and also there is another receptor called TMPRR, receptor. These are the two receptors currently, based on the pathogenetic studies. It's been found that this virus gets attached and the pathogenesis being initiated. The minute when virus enters through these receptors, so there is a viral host interaction happens. So this is a very important phase where there is an entry mechanism. There are a lot of drugs are under development, like Camostat, which I'll talk briefly soon, which is to prevent this viral entry. So the next step, what happens is there is an endosome maturation happens when soon after the viral host interactions. Then there is a process called translation happens, because it's a typical RNA virus where these polypeptide chains are cleaved. At that time, there is an enzyme called protease has been involved. This is a very important enzyme which helps these translations and this polypeptide chains cleavage. And in the next step, what happens is once this viral protease cleavage happen, it translates and this replicates, this RNA particle replicates. At this time, there is a very important enzyme which a lot of current therapies have been targeted on, which is called RNA-dependent RNA polymerase. We call it as RDRP. So this is an enzyme facilitate in these translation in RNA replication. And in the next step, what happens is it interacts with the endoplasmic reticulum and Golgi apparatus, and the virus get packaged up and get matures and assembles inside our own system and buds out, and these newly budded virions get into this atmosphere and the cycle repeats. So again, we have an entry pathway. Where is a host viral interactions? Again, why I'm walking through it again is this is a way where now we are going to target these therapeutics. There is an endocyte maturation inhibition happens. There is a translation where the enzyme called protease has been involved. And there is a translation process where there is a very important enzyme called RNA-dependent RNA polymerase has been involved, where again, Remdesivir work, which I'll talk soon. And this packaging and maturation happens. There are various molecular pathways and get released. So if we have been targeting our therapy, we have to target along this pathogenesis so that we'll be able to effectively control or eradicate this virus so quickly from our system before it causes any disease. And again, the typical clinical manifestation, which you all know, almost 85% of the patients who present to our clinic with this confirmed, either they complain of fever or cough, sore throat, malaise, and myalgia, typical like any other viral fever, or sometimes they complain of gastrointestinal symptoms like anorexia, nausea, diarrhea, And also, there are patients who have complained about taste disturbance and smell, anosmia, loss of smell. And if we ask in the history, even a week before even the diagnosis, they have been complained for this. So this is something, one of those symptoms which occur very early, where when we do a diagnosis, if we do a history, they retrospectively say they had all this problem. And again, when the virus progresses in terms of the disease process, then they develop a shortness of breath, and this can happen anything 5 to 8 days after the symptom onset. So again, many of the patients who come to a clinic, they either don't have any of those because they are tested because their close contacts been infected, or they have been with a mild disease. Another 15%, they have, they need to be hospitalized or put in an ICU. We call it a moderate and severe, which I'll, describe soon. And coming to those diagnoses, you all know that we have to do an RT-PCR molecular test from the nasal and throat swab. Now, also recent studies show that you can also use the saliva, still under validation. Hopefully it will be approved soon, where you have to put a PCR, RT-PCR to diagnose this. That's a current gold standard to diagnose this virus called SARS-CoV-2, which causes this COVID disease. And also it produces various other laboratory abnormalities, produces lymphopenia. There's an alteration between neutrophils and lymphocytes ratio, we call NLR ratio alteration. It causes elevated D-dimer, elevated LDH, elevated CRP, increase in serum ferritin, abnormal in liver enzymes, and of course the interleukin-6 get altered, which I'll talk about that soon. So coming to this pathophysiology, predominantly this COVID virus is an respiratory tract infected virus, which is associated with the SARS-CoV-2 infection. But in a small proportion of the people, almost around 15 to 20% of the people, it can also progress to a severe systemic disease characterized by acute respiratory distress syndrome, sepsis, septic shock, and with a multi-organ failure, including acute kidney injuries and cardiac injury. And again, if you go into the pathogenesis, what really causes all those moderate and severe diseases is caused by the excessive release of cytokines and chemokines. We call it as cytokine storms. So this is a small-scale study being done in China at the early part of the pandemic on 41 patients, where they have seen these various pro-inflammatory cytokines as shown by these red-colored in these letters called interferon gamma, beta, IL-1 beta, IL-6, IL-12, IL-18, and TNF alpha, and many of those chemokines have been upregulated, which you all know that which can destroy various organs and causing severe organ damage, and also producing all types of, you name any complications, our COVID infected patients can go through that. This is called cytokine storm, or called CRS, cytokine release syndrome. Hence our therapy is not just only targeted on the virus, but also on these cytokine which have been released as part of this COVID disease. One of those pathogenic features we see, which also aid in diagnosis, along with RT-PCR, is doing a CT scan of the chest, where significant number of patients, either they are moderate and severe or mild to moderate, they all present with mild shortness of breath when you do a CT scan of the chest. They also have what is called ground glass appearance, as seen in the CT, where you can see these peripheral, bilateral ground glass opacities, sometimes also been associated with consolidation. And this also can have some sort of a rounded morphology as said by the radiologist, but this is something where is being seen in significant number of our COVID patients. And also in certain instances where patients will come with symptom with an exposure history with someone at home, but RT-PCR can be negative, but this CT scan can also aid you to make a probable or possible diagnosis so that to treat this patient because they become morbid. And also I like to tell you that it is not just a respiratory virus, but also it can produce several extrapulmonary manifestations. Now we have seen in our settings, it can produce variety of problems. It can produce cardiac morbidity, like cardiac arrhythmias, myocardial injuries, myocarditis, myocardial ischemia, acute cardiopulmonary cardiogenic shock. It can also produce various dermatological manifestations, and endocrine abnormalities, particularly producing hyperglycemia and diabetic ketoacidosis, and also especially in patients who already have well-controlled diabetes, the worsening of diabetes mellitus, using severe diarrhea and vomiting, but also a variety of neurological manifestations, including stroke, seen patients with Guillain-Barré syndrome, isolated carinal palsies, and just simple dizziness and encephalopathy changes. And one of those very distressing problems we are seeing, which leads to death in COVID, is producing thromboembolism, which I'll talk about a little more on that. Also various hepatic enzymes elevations, and of course, renal kidney injuries and proteinuria and hematuria. So today, in even your internal medicines clinics, if anyone comes with any of these complications, think about COVID. So today, COVID is a differential diagnosis for anything what you have been seeing, in your clinic. Variety of cardiac manifestations including heart attacks, thrombosis, heart failure, cardiogenic shock, and myocarditis. And one of those very difficult problems which we are seeing, in our patients, especially in moderate and severe, is, it leads to various coagulation abnormalities, which are being measured by D-dimer in ferritin and troponin and LDH, where it can lead to pulmonary emboli, and which can lead to myocardial infarction and disseminated intravascular coagulations, and patients can go for typical desaturations. Hence, for this reason, we use heparin a lot to save the lives to prevent these embolism formation in COVID patients. There are some pathological work being done in people who have died of COVID disease. So again, this is a very small scale study on just 7 patients where they have done the autopsy, where you can see these lung tissue which have been stained, where you can see this lymphocytic pneumonia with multifocal endothelialitis. And also you can see this closer view of this section where you can see these deposition of microthrombi. So this COVID-19 lungs, what is shown is on to endothelial injury, widespread thrombosis, alveolar capillary microthrombi, and also it can produce angiogenesis. So this is something what's been typically seen as a pathology in the lung of COVID diseased individuals. So these autopsy findings done from China and European countries have very clearly shown that it produces microvascular thrombosis, which end up in COVID-19 vasculopathy, pulmonary intravascular coagulopathy, hypercoagulopathy, and also it alters ventilation perfusion mismatch, and it leads to ARDS. And the hypoxemia, which we see in COVID, is secondary to these ARDS, may also activate the coagulation cascade, and thereby our patients go for a desaturation. Here, for this reason, that where we administer this low molecular heparin in these patients to save the lives, so that these microthrombi can be prevented. So not everyone progress to moderate or severe or critical disease. I said at the beginning of my talk, almost 85% of the people, it presents just with a mild or moderate mild disease or asymptomatic. But in individuals who are aged, particularly 60 plus, who got any other comorbidities, particularly COPD, any cardiovascular disease, diabetes, obesity, sickle cell anemia, chronic kidney disease, and any immunocompromised state, and including in pregnancy, where it's been seen that the disease can be very severe. And also in people with HIV, where we have been doing a lot of studies at our hospital there, where we've seen if they are not on antiretroviral drugs, if they are disrupting and the CD4 is low, the chance of progression can be very severe. So this is something what we have been seeing in our patients. So many of those patients with these risk factors, they're prone to progress, and so you have to be very careful, closely monitor. So we have different staging like any other disease. So it's been developed by US National Institute of Health, which is widely being used in our clinics. Particularly, this staging is important for defining treatment. So we have an asymptomatic stage where they are just positive to SARS-CoV-2, no symptoms. And they have mild illness. It just varies from fever, arthralgia, body pain, or sore throat. So these are those two stages where we don't hospitalize them, and they don't need any major treatment. So they just treated symptomatically, and we offer the home quarantine, do a contact tracing, and isolate them. But But individuals with moderate illness, when they have a respiratory distress syndrome, even when their oxygen saturation is more than 94, we assess them. Many times they all will have abnormal imaging as characterized by the CT scan, which I showed. And also there is a 10% of the patients can progress to severe and critical. Their oxygen saturation can dip to less than 94, and they can have a severe lung infiltrate, which also along with that, any other multi-organ failure, including septic shock. But these are the patients who need to be hospitalized in an intensive care unit. I think next part of my talk is I'm going to talk more about how we manage these patients. So coming to the treatment for COVID is all based on these viral transmission and pathogenesis and the various clinical manifestations. So we treat with antiviral drugs, which I'll talk more about this soon. We use anti-inflammatories because it produces a lot of inflammations because of this cytokine release syndrome. We use anti-inflammatories like steroids and other IL-6 inhibitors, which I'll talk briefly on that. And also the newer thing is using using SARS-CoV-2 antibodies, either in the process of using convalescent plasma or these laboratory brewed antibodies, which are still under trial. So again, before we talk about these antiviral drugs, I'll again walk you through this pathogenesis again. I said earlier there is a viral entry pathway, uses to different receptors, and there is an endosome maturation happens. Then there is an enzyme called protease, which is helps to translate this virus and helps to cleave. And there is a virus called RNA-dependent RNA polymerase, which helps that translation in viral replication. Then the Golgi apparatus and endoplasmic reticulum help to maturate and releases. So there are a lot of drugs being tried. There are some of those drugs which been tried, a drug called Camostat. It is to prevent the viral entry when they enter into these using AC2 inhibitor or TMPRSS2 receptor. So this is something still under development, not much effect so far, but still under development. There is a drug called hydroxychloroquine, which many of you know is been tried, especially at the time of endocytosis. Again, the data showed it didn't work, which I'll talk to you soon on that. And also I said about this enzyme called protease, which is very important for the viral cleavage. A drug called lopinavir, which we use a lot in HIV, which has been tried, clinical trial, didn't show any promising response since we are not using this anymore. But on the other hand, an enzyme called RNA-dependent RNA polymerase inhibitor, particularly a drug called Remdesivir, which has got some promising effect, hence it's been part of the treatment guideline, which I'll talk more about it. Also, there is a drug which I briefly mentioned, not a part of the guidelines, but Remdesivir is part of the guideline, which we'll talk more on that. First, we'll talk about hydroxychloroquine. This is a talk of the hour at the early part of the pandemic, starting from India to the United States, starting from our own Prime Minister's office to the White House in the United States. So this is a drug where had shown some laboratory activity against this SARS-CoV-2 in the past. But when they started doing these clinical trials against the standard of care or with other medications, as said by this recovery trial, which is a trial which happened in UK on 11,500 patients where they've been randomized to hydroxychloroquine, to steroids, lopinavir, azithromycin, tocilizumab, and convalescent plasma, where this well-designed study have very clearly shown that out of the 1,500 patients who are randomized to hydroxychloroquine against 3,000 odd patients in standard of care, there's no significant difference in terms of primary endpoint of 28-day mortality. And also the same investigators also shown it has got no effect on prevention. Hence, the guidelines never recommended hydroxychloroquine in any of those. Also, very recently, there is another trial which is done by WHO called Solidarity trial, which again, I'll walk you through it soon, also said that this hydroxychloroquine has got no effect, anything on treatment or on prevention. Then coming to this protease inhibitor called lopinavir, which we all use in our HIV patients as part of the second line or third line treatment, where there are initial reports from China had shown it has got some activity. So following this, there are clinical trials being carried out both in China as well as by the UK group, by the recovery clinical trial group, where they have seen, so this is one particular trial where in China, they recruited almost 200 patients, 99 randomized to lopinavir, another 100 to standard of care, where they found There's no difference between the groups. In fact, mortality was at 28 days was similar in both the groups, and thereby this lopinavir was not anymore recommended. So similar effects were also been seen in recovery trial as well as in the WHO conducted solidarity trial. So again, this drug is not anymore been effective, not been recommended as part of any guidelines. So moving to the other antivirals, which particularly acts on these at the time of RNA translation. So this particular drug called Remdesivir, which again said that it inhibits this enzyme called RDRP, RNA polymerase protein, where this is a very important pathway which helps in the translation of this RNA into particles. So this COVID antiviral drug gets incorporated into the viral RNA and prevents it being synthesized and halting this virus replication. So this was the main mechanism of action of this particular Remdesivir. So this Remdesivir was initially being developed for a variety of other viral diseases, for Ebola, for SARS, MERS, which has got a very limited activity, which has been abandoned, not been used. Hence, they repurposed this drug for this COVID. So it was not newly developed. It has been developed for some other purpose, now repurposed for COVID. So how these started getting into the guidelines is on 61 odd patients in the United States, it has been used for compassionate ground. So what they found in that is not a clinical trial of giving a 10-day course. What they found them in that is almost 68% of them improvement in the oxygen support class. Less people needed oxygen. Almost 50% of them were discharged. Only 13% died. So this is something what has been seen in a single arm compassionate use. Hence they thought it has got some activity. Why not be used it? When they sub-analyzed these 61 patients, and particularly they found in people who are on oxygen support versus non-invasive, there is more benefit when they are on non-invasive as compared to invasive. And also in people with less than 50 years, it has got a more benefit as compared to more than 70 years. So following this, there are various guideline makers started doing clinical trials. So this is one of those, a very nicely developed clinical trial by the US National Institute of Health. It's a large multi-site study. So they recruited patients, a very large number of people, 1,063 patients who are randomized to either to Remdesivir or to placebo. That's along with the standard of care. So here in this, they used treatment up to 10 days. And what they found in that particular Act 1 trial is patients who are on Remdesivir, they quickly got discharged. 11 days, within 11 days, they got discharged as compared to 15 days on placebo. And also, which has been statistically significant. And also they started seeing less people died on Remdesivir as compared to people who are on the standard of care, which is not statistically significant, but on the time if you look into the numbers, it very clearly shows that there is a survival benefit in terms of mortality. And again, when they did the sub-analysis and they found that overall there is an improvement with Remdesivir, which was statistically significant, and also particularly in patients who are not receiving oxygen, it has got a good benefit, and also increasing in oxygen. But when they're on any mechanical ventilation, like in ECMO or in ventilators, it did not see any significance. Hence, you may have to give this drug a little early before they are being ventilated. So coming into these adverse effects of this drug. So again, if you look into that, this particular trial, what they have shown is there is no difference in terms of placebo. In fact, placebo had more anemia than Remdesivir, and these are all very minimal being seen as compared to placebo. There is nothing major alarming to say that this has been toxic. So this was also been followed by two different clinical trials called simple clinical trial. One was conducted on severe COVID patients, another one on moderate patients. And again, this simple trial on severe patients recruited 400 patients with COVID, and they were randomized into two different groups. One group received 5 days of treatment, another one group 10 days of intravenous Remdesivir. Where again, on the day 1, you have to give a 200 milligram loading dose, and from day 2 to 5 or day 2 to 10, then 100 milligram intravenously. So what they found in that particular trial is there is no difference between 5 days and 10 days in terms of clinical improvement, clinical recovery, and as well as in terms of mortality. So, and again, this very clearly shows that 5 days of treatment is more than enough as compared to 10 days where in terms of clinical benefits. But on the other hand, people who have been on invasive mechanical ventilation, where 10 days of treatment has got a better improvement as compared to 5 days. Hence, now our guidelines are focusing towards about 5 days is a recommended treatment of choice. But on the other hand, if the patient needing more oxygen on ventilation, you can give up to 10 days. It's based on this simple clinical trial which was done on severe patients. Also, this trial was carried out on a moderate disease, where again they recruited 584 patients in 3 different groups. One group received Remdesivir 5 days, another one on 10 days, another one just on standard of care. So again, in this particular trial, they found that 5 days was better than 10 days, and 10 days was not statistically significant as compared to standard of care. So that means 5 days of treatment in a moderate disease, which has been significantly good in terms of recovery. So coming to these adverse effects, there is, if you look into these, there is nothing major significant in terms of Remdesivir, the 5-day course as compared to the standard of care. And following these, US FDA gave an emergency authorization for this Remdesivir for the usage of in severe and as well as in critical patients, where also they recommended very clearly to do a creatinine at baseline, identify EGFR. If the EGFR is less than 30, then Remdesivir is not recommended. You should closely monitor their liver function test. This is what been recommended before initiating Remdesivir as part of this care. Once it's been launched in the United States, then our Indian manufacturers, and it started with here at the beginning of this symposium, Hetero developed this Remdesivir in a partnership with Gilead, and they get certified by the Indian regulator. So this is one of the first Indian company which got certified. And so this is the one which we use a lot in India in our clinic under the name of COVIC. And I heard it's just also been available right now in Myanmar. So the one what has been recommended is for adult patients is a 5-day course, which is 200 milligrams on day 1 as a loading dose, and then a maintenance of 100 milligram from day 2 to day 5. And in patients which are on the ventilator support and on needing more and more oxygen, you can give up to 10 days, but the recommendation is 5 days by the Indian regulator. And also in pediatric patients, especially when patients weighing 3.5 kilograms to less than 40 kilograms, you can also use this, but at a dosage of 5 milligrams at the loading dose and 2.5 milligrams from day 2 to day 5. And any children more than 40 kilos, then you can use adult dosage of 200 as a loading dose and 100 as a maintenance dose. So it's been available both as a lyophilized powder, also as a Remdesivir injections, where both can be used. In pediatrics, it's recommended to use this lyophilized powder so that you can concentrate based on their body weight. So based on all those studies and these approvals where it's been recommended for adults and children, especially who are hospitalized in severe disease and in critical disease, and the 5 days treatment is more than adequate. And also there are preliminary data now coming up, especially on simple moderate disease, and as well as there are newer studies showing probably they'll have also benefit if you little upgrade to moderate or even mild to moderate, which we don't have definite data on that. The recommendation is currently on severe and in critical cases. But on the other hand, when we started recommending these guidelines, started using this, WHO was been doing a large clinical trial, which many of you know called Solidarity trial, which I'm also one of the investigators, part of this trial. And our hospital, VHS in Chennai, has also been participating in the trial. So this particular trial has been currently happening in 405 hospitals across 30 countries. More than 11,000 adult COVID patients been recruited for this trial. It has got multiple arms. It has got an arm on Remdesivir. Almost 2,750 was been recruited when the analysis happened on interim analysis. 954 on hydroxychloroquine, and 1400 on lopinavir, 650 on interferon with the lopinavir, and 1400 on only on interferon, and remaining 4000 on no study drug but on standard of care. But again, this trial is still ongoing, and at the beginning of the trial, both hydroxychloroquine and lopinavir and arm with the lopinavir interferon was closed. So that means because that did not work, the restore. So the trial continued with the remdesivir and as well as with interferon and with the standard of care. And a couple of weeks back, there's an interim trial results who have been announced, which some of you know that, which very disappointingly showed that arm on lopinavir, of course, when remdesivir was compared against standard of care, did not have much benefit, which we thought there could be a benefit, as well as the interferon as compared to standard of care. And also in this particular trial, 1,200 patients died at median day of 8. 28 mortality was 12%. And in this particular trial, no study drug was definitely reduced mortality in unventilated patients or any other subgroups of entry of characteristics, initiation of ventilation, hospitalization. But again, we can't just go with one particular trial because this trial also recruited very sick people, and in many countries. So many of them, these drugs would have got a minimal effect because they already had been, very sick on them. I just want of this, I'll just show you 4 graphs on these various drugs. When lopinavir was compared against the control, what you can see these, there is no difference between standard of care, that is without any study medication, just a supportive of oxygen, steroids, and low molecular heparin. Again, interferon is an arm where did not show any benefit, statistical significant. And also, surprisingly, remdesivir in this only trial which has shown there is no mortality benefit, but on the other hand, we expect some other benefit analysis going on. Of course, hydroxychloroquine did not have any benefit at all. Now, the trial is still ongoing. We have been recruiting in our hospital. Even today, we recruited participants in our clinic for this trial, global trial. We are still continuing with the remdesivir and the standard of care. We like to look at other possible benefits, not just on mortality alone, but on the other hand, quicker recovery, what will happen to the post-COVID era, whether someone who received remdesivir will have less effect. And this type of analysis, we want to look into that. So the trial is still ongoing with remdesivir, but on the other hand, we are also been adding some of the other drugs which can also have action on IL-6. So again, you'll keep seeing more and more. It's an adaptive design. More and more drugs will be added to the solidarity trial. But again, after seeing all those results, I think this is something, if you had to give an antiviral, don't wait the patients are really sick. I think you have to start either the moderate or mild to moderate before they can begin profoundly being sick. Also, these patients also need variety of other supportive medications because it produces a lot of inflammation, as I said earlier, that it induces cytokines and producing cytokine storm. So you may need a lot of anti-inflammatories and other adjuvants. So other than this remdesivir, there is a drug called Favipiravir, which is also being developed by many companies, which has been used in resistant influenza virus, which has been approved for use in Japan and in China for those indications. So their repurpose is for COVID, but we don't have much data on that. There's a Japanese observational study, what they have done, and they've shown some benefits, but on the other hand, it was not a comparative study. But if you compare this with the no treatment, there is no difference. In fact, even in our clinic, we see the similar response in people who did not receive treatment. So based on this, I won't recommend Favipiravir as a drug of choice. And also there is a trial done in Russia on Favipiravir in 2 different dosages, one at 16 milligram BID on the day 1, then 600 BID twice daily up to 14 days, and another one on 1800 milligrams on day 1 and 800 on twice daily. It was compared against the standard of care in Russia, but in a very small proportion of the patients. Again, the investigators said at day 5, they have seen some significance in terms of elimination of this virus. But if you look into that 10-day period, there is no significance. So I won't recommend based on this data. But on the other hand, these investigators said that there is a quicker recovery in terms of temperature, but I won't use this as an endpoint to recommend. Hence, again, this lack of this evidence, the guidelines are not recommending today Favipiravir as a drug of choice. Hence, again, we can't recommend this in moderate and severe disease. In mild disease, can we give this? At this time, we don't have any definite answer. we need another proper randomized clinical trial to do this. But again, with this drug, there is a huge pill burden. Patients have to swallow a large number of pills at 14 days, also many times in asymptomatic and mild symptomatic without any such medications. Our patients do very well. At this time, we don't have any recommendation on Favipiravir. I talked about other supportive treatment. There is a large trial called Recovery trial, which one earlier talked about hydroxychloroquine and lopinavir. Again, in that particular trial, they also randomized patients to receive steroids versus just a standard of care. They used dexamethasone 6 milligrams once per day, either orally or intravenously up to 10 days. What they found in this particular trial is quite a large number of patients been recruited in the UK, where they found that patients who are on dexamethasone, there is a 35% reduction in mortality, especially in people who have been ventilated, and in 20% reduction in mortality in patients who are needing oxygen. So, but on the other hand, there is no benefit was seen people who did not have any respiratory support or who don't need any oxygen. So that means someone comes to your clinic who is COVID positive, asymptomatic, mild symptomatic, who don't need oxygen support, don't prescribe steroids, which you all know that steroids sometimes can harm an infectious disease. Particularly, it can cause more viremia, it can cause immunosuppression, causing more disease. Also, there is slow disappearance of this virus because it can produce more viremic. Hence, don't use it in your clinic unless they need an oxygen or they have any respiratory symptoms. Otherwise, it's not going to be benefited based on this recovery trial. Then what about this convalescent plasma that is an antibody? So again, this is not new in infectious diseases, which we have used in H1N5, we use in H1N1, and as well as in a variety of other diseases where convalescent plasma had been used as a neutralizing antibody to control against these infectious agents. Again, similar principle had also been developed for COVID. There are a small-scale clinical trial done in Wuhan, in China, where they have found in the severe disease, where patients who are receiving convalescent plasma as compared to controls has been benefited as compared to the very critical disease, where again, similar observations are seen in some parts of the world, but not everywhere. This is again a large series which was generated from one of those US clinic on 35,000 patients in Mayo Clinic in the US, where they have seen 7-day mortality of 9%, and within 3 days of diagnosis, and 12% if transfused 4 or more days. And also they have seen convalescent plasma with higher antibody titer has lower mortality than plasma with the lower antibody levels. It's roughly almost 35% reduction in overall mortality. But again, this particular study did not have any comparative arm. So another trial happened in India, now just got published, called PLACID trial, which was done by our government on 400 odd patients, where they used standard of care versus convalescent plasma, where they did not see any mortality benefit. But again, there are good and bad answers with convalescent plasma, but now trials are currently underway. Can we give this much earlier rather than patient progress to severe or critical? Can we give it moderate or even at mild to moderate so that you can use this neutralizing antibodies, control the virus replication effectively before they start developing any cytokine release syndrome? These are all work in progress. At this time, we don't have any good answer on this. Right. So coming to the standard of care in India, I will be ending my talk soon just to show that. So today with someone who comes to your clinic with the asymptomatic mild, we just do a home isolation and supported treatment. But on the other hand, someone coming with moderate disease or critical or severe disease, we hospitalize them, we give them steroids, we give a lot of methylprednisolone at the beginning, now dexamethasone. This is very important because it suppresses cytokines. We give low molecular heparin. If it is moderate, we give once daily subcutaneous of 40 milligrams. If it is very severe, up to twice daily of 40 milligrams. Because this has been very important because I said at the beginning part of my talk, it produces a lot of thrombosis and microthrombi, which can also lead to a severe hypoxemia. You need supportive oxygen, high flow oxygen, starting from 2 liters to 15 liters. And sometimes you may need a mechanical ventilations. We try to avoid that. Sometimes we give CPAP, treat all the comorbid conditions and supportive medications, make sure that their diabetes under control and cardiac conditions under control. Intravenous Remdesivir has been recommended in our clinic in all hospitalized patients, either they are moderate, severe, or critical, or even to mild to moderate. And if they have raised IL-6 and the CT scan showing ground glass appearance, and if they are in respiratory distress, we also use anti-IL-6 inhibitor, a drug called tocilizumab. It's a little more expensive drug. It's again a monoclonal antibody, which has got immense clinical benefit, but some of the trials have not shown huge benefit, but clinically it has shown in individual clinics. And we do what is called prawn ventilation that really helps our patients, which our intensivist does this. And convalescent plasma, we used a lot, but now we are waiting for more results when to give them. Either you do as a moderate disease or wait up to they are being severe, or even give much more on that. There are a lot of trials being happening. I think this is something what similarly you can use in Myanmar in your patients, because Remdesivir has been currently available in your market in Myanmar. Again, the timing of this treatment is very, very, very important. So if you preserve the drugs till they are being progressing, then may not work. Antivirals with Remdesivir, you should start giving early, soon after the diagnosis, and if they have respiratory distress, and you should start that. And convalescent plasma, we did earlier at this time, but probably I feel you have to upgrade. Now trials are underway. And again, steroids, don't give at the asymptomatic and mild symptomatic, only if they are needing oxygen. It really helps. Otherwise, it can cause more harm on them. And other adjuvants like low molecular heparin, which has been needed because these are some of those you really will help a patient to prevent death because of the micro thrombi, which happens during this pathogenesis process. So I'm going to conclude stating that some of those take-home messages from these trials. So many of us are in the infectious diseases. We all have done traditional clinical trials in the field of HIV, and myself personally been involved in several drug development in HIV. We did several clinical trials in collaboration with the US NIAID. So one of the first drug for HIV was AZT for HIV, which turned out to be have an effect that was modest, but that was not the end game, because building on that, every year we have now better antiretrovirals. In HIV, we have multiple drugs today. From one trial, we are able to build on. Today, we have got what is called combination therapy. Similarly, I feel Remdesivir alone may not help, because that's what we have seen now in Solidarity trial, as well as in some of those trials, which has not given full benefit. But on the other hand, giving a combination of Remdesivir with steroids and using monoclonal antibodies which are under development probably can have very immense benefit, which now trials are being underway. We need to wait for some of those results. Also, before I end my talk, I like to tell you that there are a lot of interactions happens between Remdesivir and a drug called hydroxychloroquine. So initially, early part of the pandemic, hydroxychloroquine has also been used not only for treatment, but also prevention. So many of the doctors, nurses, healthcare workers, frontline workers, and community workers, they're all been swallowing hydroxychloroquine. So that's a time, and US FDA gave a very serious warning. There are interactions with Remdesivir. If unfortunately, if anyone has been infected while they're on prophylaxis with the hydroxychloroquine, then Remdesivir may not work well. So today, hydroxychloroquine is not working either as a prevention or for treatment. So again, don't recommend this into your country at this time, because we don't have any evidence on this. But again, if you use this, if you need to use Remdesivir, probably you may not have that effect because of these interactions. So I'm going to briefly end my talk and by walking through some of those work what we have done in our hospital in Chennai, which is VHS, Voluntary Health Service, a large multi-specialty hospital where I run the Division of Infectious Disease. Now COVID treatment center has been part of it. So we saw the first case sometime in mid-March. So we have set up a COVID task force, which consists of key infectious disease doctors, critical care doctors, diabetologists, internists, our nurses, key nurses, and some of the administrative staff who takes the decision, and laboratory staff. Again, if you have been setting up this COVID treatment center in your hospital, you need to set up a COVID task force. The task force is very important. One, to implement infection control practice, make sure that all the staff who are going to care are being properly trained in disease management, in infection control practices, how to wear the appropriate PPE and doing donning and doffing, and make sure that they properly practice this, and also make sure that they are being updated with the appropriate knowledge on COVID management, something in a task force. We keep meeting every week or every other week, keep updating among ourselves, still happening every week. And this is what our first case was diagnosed in our hospital. So when we started seeing this, we converted a small portion of our emergency room for triage. It's not just for people who are confirmed COVID positive, but also people come with suspicion, or we can't mix with other patients. So we have a dedicated facility at the emergency room. So people who have been suspected, so where appropriate nurses dressed with the PPE, they do all the temperature check and everything. And if they have a symptom questionnaire, if they have any of them or exposure history, travel history, or any of the symptoms, then we refer them for COVID testing. And also we standardized all these assays in our lab, got certified, which is very important in our country. I think you need to follow your own regulation in Myanmar to get certified to do COVID testing. RT-PCR is a gold standard. And also, we had set up an outpatient clinics exclusively for COVID patients, where physicians and nurses are appropriately trained and take appropriate infection control practices. We see anything from 7 to 10 new cases a day in our clinics. And now we have treated more than 1,500 patients in our hospital, with COVID. And I said earlier, 15% of the patients who might be moderate, severe, or critical, they may need an inpatient. So we have set up a dedicated COVID intensive care unit with 10 beds, with high flow oxygens, with ventilators, CPAPs, and with all the trained staff. And people who don't need ventilations, we also have set up different types of wards with individual rooms, with semi-private facilities. We have a 55-bedded now facility for COVID patients, with all the beds will have high flow oxygen, because you do not know when the patient will desaturate, so that you don't need to move them to a ventilated facility. So every bed have facilities to supportive oxygen, and it's what is called the isolation ward. So if you have been setting up in your hospital, you need to identify a particular block which are not mixed with elderly patients or diabetic patients, or with the pregnancy clinic or HIV clinic. It should be isolated from all those, so that other patients won't be being affected. So we have treated more than 400 moderate and critically ill patients in our hospital, and among them 25 people have died. So again, mortality is much less as compared to other hospitals in terms of these critical patients. And again, predominant risk factors for death in our hospital is old age, more than 70 years. We have treated people anything from 2 years to 98 years old in our hospital. So people who have died had hypertension, diabetes, or renal disease. People who don't have much comorbidities or younger, they don't die. They recover, very quickly. There is another way where we also manage COVID patients in our hospital is people who had symptoms of COVID, but on the other hand, their RT-PCR is being negative. So again, there are studies have shown where these RT-PCR can be positive, can be negative, but on the other hand, I'm not sure that the slide slipped away. I'll go back to this slide again. Okay, right. So RT-PCR can be negative, but on the other hand, they can have COVID. It's quite possible because the sensitivity is only 75%, but they have COVID-specific symptoms. These are the people we subject to CT scan, where they have ground glass appearance, then we feel that it could be possible due to COVID. And when you run tests like IL-6 and ferritin D-dimer and CRP, invariably they have been elevated. And we manage the patients similar like a COVID patient. We keep them in the isolation facility. We give them also supportive oxygen. We give steroids. We give low molecular heparin. And also we try to do an antigen test, try to find if they are antigenic or they would have developed any antibodies. There are instances sometimes they would have developed a COVID a couple of weeks back, but now the virus would have got rid of their system by their own immune system. But now because of the CRS, cytokine release syndrome, they would have been sick by the time they would have developed antibodies. So some other things which you can consider in your clinics. But whether you can give Remdesivir in these patients, we don't have any data on that. So currently we give Remdesivir only on confirmed RT-PCR positive people. In negative people, we give all the other supportive management. But this is something what 25% of your patients in your clinic can present with COVID symptom, RT-PCR negative, but use CT scan and other supportive lab investigations to manage them. And also in our hospital, we also do what is called post-COVID follow-up. Once a patient's either seen in the outpatient clinic, we do a strict 14 days of home quarantine, or if they have been hospitalized, they have been there anything from 7 to 14 days, then we discharge them, ask them to come after 1 month for a review, then on 3rd month. In this period, we do a very detailed clinical examination, review their comorbid conditions. And also what we are seeing is variety of other post-COVID complications in these patients, starting from fatigue, new onset of heart attack, worsening of the diabetes, a stroke, isolated cranial palsies, and variety of these complications. Hence, post-COVID follow-up is very important in these patients. Also, we do the lab investigation, relevant ones, and repeat RT-PCR is not recommended by the CDC because it can be possibly up to 3 months, because this RT-PCR can also detect the dead RNA particles. Hence, we don't do that. But on the other hand, we do an antigen test. If they are negative, we assume that they are not infectious to others. And we try to do antibody test on the 3rd month or anytime after 6 weeks and counsel them for convalescent plasma donation if they have been antibody positive. These are some of the things we do in the post-COVID follow-up. Again, in your hospitals, if you're setting up COVID clinics, also set up a post-COVID follow-up clinic, because it's very important to follow them up in your clinic by your trained physicians. So I'd like to end my talk stating that there is no compelling evidence or a benefit on the usage of hydroxychloroquine in patients for treatment or for post-exposure prophylaxis or for treatment or prevention. Remdesivir, based on Act 1 trial, simple trial, and as well as some of those studies done in different parts of the world, have shown reduces time to recovery in patients with moderate and severe disease. But on the other hand, Solidarity trial, which is more focused on mortality, did not show a benefit from Remdesivir. But on the other hand, there are sub-analysis happening whether it is for other benefits, which has also been important when you have currently no other approved treatment available. So till now, Remdesivir is approved as part of the guideline, mainly for moderate and severe disease. Steroids, based on the recovery trials, improve survival, particularly patients who need supplemental oxygen and mechanical ventilation, which has become a standard of care. Low molecular heparin, in our experience, very clearly prevents death, because the pathogenesis very clearly shows that people die of COVID disease because of this thromboembolism. People desaturate because of thromboemboli into the lung. So heparin really prevents death. And convalescent plasma may provide a benefit in patients if initiated yearly, but we don't have any definite data on that. Guidelines are not recommending. Hopefully, over a period of time, there are these, not only just convalescent plasma, but also there are other monoclonal antibodies, which are now being tried both in very early infected people as well as in late stage, probably will become part of our guidelines. So these are some of those emerging therapies under evaluation. There are different trials currently happening by the NIH group called Active 2 and Active 3. They use variety of monoclonal antibodies, which are all lab-grown monoclonal antibodies, which are used. Active 2 is in people in outpatient clinic. Active 3 is one in inpatient trial. Some of those monoclonal antibodies very recently have shown not been beneficial. Some of them have some beneficial. For example, the Regeneron one, with the one which is targeted on the anti-spike monoclonal antibody, and where is the media news that President Trump received this. I don't have a definite answer on that, probably recovered, and also some other case reports showing this. Also, a variety of other monoclonal antibodies under development, under trial, we need to watch on that. Also, a variety of other immunomodulators, not only just on IL-6 inhibitors like with tocilizumab, but also one called parasitinib, which is a JAK inhibitor. There is one which we are using in right now in Solidarity's trial is called acalabrutinib, which is called Bruton tyrosine kinase inhibitor. Also one called sarilumab from Regeneron. And of course, tocilizumab is currently being used in our clinics. And of course, now Hetero also has got this. So this is something that's got some benefit on our patients, can be a supportive treatment along with these antivirals. Also, now several trials ongoing on a combination of antivirals and as well as monoclonal antibodies and these immunomodulators. These are some of the things where we need to wait for it right now. So we don't have any definite answer. I personally feel COVID management is going to be not just one drug. You need an antiviral, you need an anti-inflammatory, you might need an monoclonal antibody. At this time, you don't have an answer. You need an antithrombotic drug like low molecular heparin, and of course, supporting oxygen, managing their comorbidities, and with our dedicated staff and following all those infection control practices. At this time, I thank you very much for your patient listening. I'll be taking up questions at the end. Thank you very much. Back to the host.
Thank you, Dr. Kumaraswamy. Thank you for taking us through the disease, the current status of various drugs, the management protocols, as well as the new therapies which are under investigation. On that mode, I will request Dr. Muang to give his perspectives on COVID-19 in Myanmar. Over to you, Dr. Muang.
Thank you very much to have a chance to present my talk on COVID-19 in Myanmar. Good evening, everyone. My colleagues in Myanmar. I'm going to present COVID-19 in Myanmar. I'm going to present 4 sections of my talk divided into late arrival of COVID-19 to Myanmar, preparedness of COVID-19, preparedness for COVID-19 in Myanmar, responses in Myanmar, and current situation in Myanmar for COVID-19. First, I'm going to present a late arrival of COVID-19 to Myanmar. As you all know, Myanmar is a neighbor country of China, and Myanmar has long border sharing with China, maybe 2,200 kilometers or 1,300 miles. But we did not see COVID-19 very early of 2020. WHO announced COVID-19 outbreak as pandemic in May 12, but we saw first case in March 23, 2 people returning from US and UK. They stay in Interim Township in Chen State. And then at that time, we were the 157th country reported to have COVID-19 infection all over the world. But now we are at the position of rank 151 in per million affected population by 27th October. We first saw local transmission cases on March 27 as case number 8. She was a 60-year-old tour guide woman, and she's not been abroad within 14 days, and she had contact with French tourists. Then we got first death of COVID-19 on 31st March. He was a 69-year-old man with nose cancer, and he was on radiation and chemotherapy. He was case number 5. Many people propose so many causes or reasons for late arrival of COVID-19 in Myanmar. These are some claims or some reasons. The first reason would be strict measure that China put in place to control the outbreak. And the second would be the relative paucity of international flights to Yangon and Mandalay. And that would be the warmer climate of Myanmar. But it is very unlikely that other countries of South Asia are having COVID-19 infection at that time. The last reason would be the paucity of or rarity of COVID-19 infection in Yunnan, which is a immediate province in China, which is contact with Myanmar. It only has 188 confirmed cases and 2 deaths by the 3rd week of July. But there were rumor and doubt on transparency of Myanmar government. Some people thought that Myanmar government is hiding positive cases from public or international point of view. Let's look at the preparedness of COVID-19 infection in Myanmar. At first, we couldn't perform COVID-19 PCR in Myanmar until February 21st. National Health and Rangoon started to perform PCR on February 21st. At that time, Myanmar received 450 test kits from Armed Forces Research Institute for Medical Science, Thailand. Government formed 3 committees to combat the COVID-19 infection in 2020. The names are very confusing. The first committee would be Coronavirus Prevention, Control and Treatment Central Committee, and which was founded in January 30th. The next committee has very similar name, National Level Central Committee on Prevention, Control, and Treatment of Coronavirus Disease, COVID-19, on March 30th, 2020. So the names changed from coronavirus to COVID-19 at that time. The last committee would be COVID-19 Control Emergency Response Committee, which was founded on March 30th, 2020. The second committee was led by National Councillor Dr. San Suu Kyi. The Department of Health produced a lot of guidelines. The first guideline for COVID-19 was announced on the 31st January 2020. Then these guidelines are updated appropriately. On August 25, there's two guidelines on a single day. Because of the emergency nature, there's some errors are noted in the guidelines. There's some claims or some blame on government that we have weak power to test PCR for COVID-19 infection at first. One of the journalists asked the Minister of Health, Dr. Mietui, and he answered like that: just come and see us. We have prepared everything we need. You may be surprised to see what we have done so far, like that. But there's some rumors and some news on social media that we did not have enough protective materials like PPE all over the Myanmar countries. One of the senior anesthetists tried to do mechanical ventilation in COVID-19 patients. She did not have video laryngoscope or PAPR system. So her glass was blurred due to fogging from marks and face shield. So she removed the eye shield to get the clear vision, and she successfully introduced endotracheal tube on the patient. Later, she got infection after that. She was the first healthcare personnel who got infection in Myanmar. Some people and most of the public think that we have successfully contained the virus in the earlier time, say up to June, July. There's a sampling that EU and United Nations praises the success of Myanmar to contain COVID-19 infection. But according to the United Nations report, among the 11 countries of Southeast Asian countries, Myanmar lies very low in the ranking system. Myanmar has 8.6 doctors per 10,000 population, 10 nurses per 10,000 population, and 9 beds per 10,000 population, according to the United Nations report. We only have 2 broadband connections for 1,000 population. So the United Nations thought that we have weak health system to combat the COVID-19 infection. And United Nations raised the concern for Myanmar and Philippines to combat the COVID-19 infection at that time. There's some surveys on COVID-19 infection in Myanmar. The first survey I'm going to present is Awareness, Perceived Risks, and Protective Behavior of Myanmar, which was done in March 2020. 597 participants are included in that study from Rangoon and Baku. 97.8% of participants heard about the COVID-19 infection. 29.3% of participants knew that it is a virus infection, and 66.6% answered droplet infection, and 29.6% answered direct contact. 17.3% did not know the signs and symptoms of COVID-19 infection. 54.8% knew that hand washing could prevent the infection. 35.9% acknowledged being age 65 was a risk factor for COVID-19 death. 42.3% relied on mass media for information on COVID-19 infection. Most trusted source of information was mass media like radio, television. Only 25.3% answered Ministry of Health and Sport media as a main source of infection, a source of information. 86.6% achieved low score on today knowledge score. So conclusion, they concluded that no enough knowledge and inadequate protective behaviors among Myanmar people. So awareness raising activities and mass media health education are urgently needed. The second survey would be community insights from Asia Pacific region. There's four countries and 1,528 participants included from Myanmar. If you look at the chart, you can clearly see that younger populations are most participants in that study from Myanmar. Actually, risk persons like elderly more than 65 should participate than younger participants. Myanmar has 100% for knowledge score in that survey, where Pakistan has only 91%. Regarding the knowledge on COVID-19 spreads, 3.1% of Myanmar answered as don't know. Regarding the risk perception, most of the Myanmar believed that COVID-19 was very dangerous. Regarding the protective measure, most of the Myanmar know that washing hands, wearing masks, and staying indoors are effective, but other protective measures are less well known in participants. Regarding the information they received, moderate number of participants from Myanmar did not know what to do if they have COVID-19 symptoms, and they did not know the risks and complications of COVID-19. The last survey was epidemiological characteristic of SARS-CoV-2 in Myanmar. The survey included 336 positive cases from Myanmar from March 23rd to 30th July 2030. They found that the reproductive number was 1.44 or 1.32 by two methods. I'm going to present for the responses in Myanmar for COVID-19. As you all know, COVID-19 is a very new infection for human society. So we do not know exact nature of the virus and what will happen in the future, how to treat something like that. So we have uncertainty on COVID-19 infection. So we face very difficult to do risk communication for Myanmar people. We did a lot of repetitive measure, something like temperature screening at the airports. Another example is preventing the entry of ship into the Myanmar. There was a ship called Silver Split Cruise. That cruise was planned to enter Myanmar in early March. Myanmar prepares to welcome the tourist cruise at that time. Then they announced then the government announced that they are going to allow the ship. There was an outcry from public in the social media like Facebook. So suddenly, after an emergency meeting, Myanmar cancels cruise ship visit to Myanmar. As a developing nation, Myanmar has a lot of migrants working abroad, and students are studying abroad. Once infection spread all over the world, they have to come back home. So we set up a coming back home plan and set up a quarantine plan on large scale. Regarding the education, March and April is known for the exam season in Myanmar. High school examination took place successfully, but several universities faced protests by the student to postpone the ongoing exam. On March 24, one day after the first case, all universities shut down and postponed their exams. We in Myanmar have internal conflict between Thermidor and army and ethnic armed organizations. One of the WHO workers was killed in Myanmar while he was collecting COVID-19 samples in Rakhine on 21st April 2020. He was Myanmar. He was driving a well-marked United Nations vehicle when it was hit by a gunfire in the Rakhine state. Myanmar Army or Thermidor released statement on ceasefire interface on May 10. Then the plan was extended up to now. Myanmar Health Ministry Minister Umyatwi warned in June, July that there is a risk of COVID-19 waves in Myanmar. There's some plan to relieve the economic burden caused by COVID-19 in Myanmar. For example, we do not have to pay first 150 units of electricity for every household all over the country, and some millions of people receive cash supply from government. Like other countries, we face a lot of social stigma on healthcare personnel and COVID-19 patients. Healthcare personnel are rejected by their tenants from coming back to their hostel or their apartment or their rooms. There's some discrimination on COVID-19 patients in Myanmar by their neighbor people. If you ask what we are on the controlling policy of COVID-19, containment or mitigation, I have to answer we are on the containment policy. At first, we call it all swabs, and all swab positive people are traced back 14 days prior to their results. And positive people are classified as patients, and all of the positive people are hospitalized, and they check their swab again until repeated swabs show negative result. It may take over 1 month for some individuals. But now we change the policy, and now most of the patients are discharged on day 11 if they do not have any complications and they do not have any comorbidity. All identifying contacts are isolated and tested in community facility quarantine center. At first, we kept them for 21 days in the quarantine center and another 7 days in their home. So total 28 days for quarantine period. Now we changed the policy. So quarantine period faculty quarantine period is now 14 days, followed by home quarantine 7 days. The interface board, some people expressed their concern that there's some risk of failure of containment policy in Myanmar because of the limited resources. Now I'm going to present the last portion of my talk, current situation of COVID-19 in Myanmar. From the mid of May, there's some loosening of restrictive measure in Myanmar. Shops are allowed to open, some businesses are allowed to open. But on August 16, a 36-year-old a bank employee was tested positive in Rakhine. She doesn't have any contact with COVID-19 patient, and she didn't have any foreign travel. After that, we see more positive cases day by day. So such of the COVID-19 infection, what we call second wave, was started from the Rakhine state. Actually, Rakhine state has no internet access. Internet shutdown has been in Rakhine state for almost 2 years now because of the internet conflict. Then we saw a lot of clusters cases in Yangon. Among them, music zone karaoke bar cluster was the biggest one and very popular. This is some problem with breaking the rules and regulations of COVID-19 in Myanmar. One of the Myanmar pastors was charged with breaching the COVID-19 rules and regulations for performing religious services in Myanmar. There was also a lawsuit related to COVID-19 rumor. One of the reporters from Nebido was sued for Facebook comment about COVID-19. The COVID-19 cases are growing day by day, and we are seeing growing number of cases. So we no longer perform PCR tests in time. At first, doctors from the National Health Lab did not accept the result of rapid tests, antigen tests. Now they changed their mind after the advice from the WHO. We started to use the rapid antigen tests all over the country. If you compare the first initial wave and second wave in Myanmar, you can see like that. First wave is almost invisible. Second wave is enormous than first wave. Government plan to start the stay at home order in Yangon and all over the country. From September 20, stay at home order in Yangon region except Kokujang was started. Nearly 77% of the confirmed cases and 66% of deaths in Myanmar are reported from the Rangoon region. According to the WHO, there is a high suspicion of community transmission in Rakhine State and Rangoon. WHO still classifying Myanmar as cluster of COVID-19 cases, not community transmission so far. But they admitted that there is a high risk of nationwide spread in Myanmar by WHO. As you can see, according to the WHO, we have partial lockdown status, we have restricted transport, occupation sectors is banned, public gathering more than 30 people are banned, and masks are mandatory in Myanmar. As other countries, we need a lot of new hospitals. So we've started to construct the mixture hospitals in Rangoon first. And then there's a plan to build three tank hospitals in Mandalay also. At first, we were late to see the COVID-19 infection in Myanmar, and Myanmar was the 157th country reported to have COVID-19 infection, and ranked 151 in per million affected population. But according to the WHO top 90 country list, we are at the number 75. Myanmar is one of the countries to have a general election in 2020. So we are seeing a lot of rallies these days. Most of us are anxious or worried about the surging of infections after rallies. Then this is my last slide. If you put the all community cases on the Excel, we can see like that as shown in blue line. And so it is something like polynomial growth in order 4. And if you draw the focus line in red dotted line, Excel shows like that. So according to the Microsoft Excel polynomial growth, we will see peak in late November. So we just pray to our Buddha that the Microsoft Excel is right. Thank you very much.
Thank you, Dr. Muang, for giving us the perspective and the journey of COVID in Myanmar. I think currently, as you said, there are about 1,000 patients coming up, but there are emerging therapies, new therapies, and vaccines also probably will be coming up soon. So we have just some time for a few questions. So I'd like to put forward this question to Dr. Kumaraswamy. There's one question. So do you use antigen test kit for COVID-19 in daily practice?
Right. So this diagnosis is depending upon what are those assays been approved in your country. So in India, currently, the only approved assay for diagnosis is by RT-PCR for COVID. But on the other hand, in our hospital, we use antigen for other reasons. For example, someone who is RT-PCR positive come and get hospitalized. So after a week of therapy, before the discharge, we do an antigen test to find whether they are still antigenic or they'll be infectious to others. So we do a rapid antigen test. If it is negative, then we discharge them. But of course, we tell them to make another 7 to 10 days of home quarantine. But on the other hand, there are some parts of India, they're also using rapid antigen tests, similar like Myanmar, for diagnosis. So the recommendation is someone who is antigen positive, you can consider as antigen, they are COVID positive. But if they are negative, then you also have to repeat an RT-PCR, because antigen positive, antigen negative, but RT-PCR can be positive, because antigen will be positive only if they have been symptomatic. And also in someone who is infected today, maybe 4 to 5 days after they are infected, they can start shedding out antigen, and they can start shedding antigen for next 4 to 5 days. And after that, they may not have antigen. So they might be COVID positive, but antigen won't be there, but still they can transmit infection to others. So I think antigen test is very tricky. If they're positive, you can take it as positive. But if they're negative, still you have to do an RT-PCR. So only good thing about this antigen test is, which is cheaper, and you don't need a sophisticated lab and sophisticated technician. It can be done, at the grassroots level. Is a simple, simple rapid test. Yeah.
And what is the turnaround time for the reports?
RT-PCR takes anything from 4 hours to 6 hours, depending upon the lab. But antigen test, you can get the diagnosis within a few minutes. So you just take the swab from the nose, just put it up in the buffer, wait for it to get mixed up. Then you take a drop and put it like in the small card-like thing where you can show the band. So it takes hardly 3-4 minutes, not more than that.
Okay, Dr. Muang, over to you. So are you doing the rapid antigen test or the RT-PCR for the diagnosis?
Now we are using both of the tests. At first, we use PCR. Then we have a lot of working burden of PCR, performing the PCR. So we started to use a rapid antigen test 1 month ago. As Dr. Kumaraswamy said, we prefer to use rapid antigen test in symptomatic person.
So this question is for you, Dr. Kumaraswamy. So how many days is it recommended to give heparin?
Right. It's a very interesting question. There is nothing like a hard-fought rule. So we give low molecular heparin in all the hospitalized patients, not in outpatients. So as long as they are as an inpatient care, so which can be anything from 7 days to 14 days, we keep giving this low molecular heparin. When they're discharged, we change them to these oral, thrombotic, tablets. So as long as they are in the hospital, give, because it's very hard to administer that at home, because you need to send a nurse or someone to do that. And also, while you're giving low molecular heparin, you also have to closely monitor their other blood investigations and INR, so that they should not cause more bleeding also. So I think I will do that in under supervision in the hospital.
So Dr. Muang, one question to you. Do you think that the control measures at the present time is enough to control the wider spread of infections?
I think that most of the effort we are doing is just emphasizing on affected people. We should more emphasize on prevention measure. I think we need to communicate public about the risks of COVID-19 infections. We need to emphasize on risk communication these days.
Sure. And so some questions specific to Remdesivir, Dr. Kumaraswamy. So it's new to Myanmar. So can it be given to those patients who are having HIV therapy or who are already receiving HIV therapy? So can these be given to them?
Yes. So Remdesivir does not have any interactions with any of those HIV medications. Now, we have been giving routinely, even in our hospital, where we follow a very large number of more than 10,000 patients with HIV. So now we have a series of 100-odd patients who are co-infected with HIV and COVID, where almost 15% of them need inpatient care and Remdesivir management, which we had given. And they were also being with a variety of different antiretroviral medications, majority of them on tenofovir, lamivudine, and dolutegravir. There are also people with the protease inhibitors, with arachnavir or lopinavir and darunavir. So there is no appreciable interactions between Remdesivir and any of those antiretroviral medications. Only thing you have to be very careful that before you give Remdesivir, you need to do their creatinine and calculate their glomerular filtration rate before you give that. Anyone less than 30, it's not been recommended. So when someone who's on HIV therapy, particularly tenofovir, there are possibilities their creatinine can be elevated. So you need to be very careful, otherwise no interactions with the HIV medications.
One more thing, what we noticed is that the mortality rate is high with those patients who are having high comorbid conditions like renal or cardiometabolic comorbid conditions. So in these, because they're already on some medication, so is there any drug interaction or monitoring which has to be done for these patients?
So again, these are drugs which we are going to give just for 5 days, maximum is 10 days. And we give only in a needy population. We are not going to give all the asymptomatic or mild symptomatic. Yeah. So, and if you look into the benefits based on most of the studies, except this solidarity, yes, even benefits in terms of reduced hospitalizations and people going into the mechanical ventilation. But these drugs, when they have been mixed with other medications, you have to closely monitor them, particularly their renal functions. Better to do that very systematically every other day. And the liver function tests, these are the very important things. We'll do that. And many times when they're on polypharmacy, there are possibilities of producing leukopenia. And so closely being, monitor all this. So it's very important if they are being elevated liver enzymes, elevated creatinine, I won't recommend to give Remdesivir because it can cause more harm.
Yeah. And what are the common side effects which you have observed with Remdesivir in your?
So what I have seen in our hospital is people who have got a kidney disease or creatinine elevated, when you give them, it further worsen. So that's the only thing, I have seen. So might be out of the 400 odd patients, might be 2 or 3 have mild elevated liver function tests, but they're all settled once the therapy has been over. So I closely monitor them, but otherwise there is nothing significant to disrupt the drug.
There was one follow-up question after the heparin. So for how long do you recommend the oral anticoagulants?
So I may give up to 3 months. Again, depending upon the patients, if they have already comorbid condition of diabetes and hypertension, I may keep giving aspirin, maybe rest of the life, because we do not know about this disease. It is only 7-8 months old. We do not know how long these effects of these microthrombi last. And again, many of the patients who are on cardiac and they are being on aspirin for the rest of their life if they are not being contraindicated. So, but we closely monitor them. But at this time, if they don't need as part of their comorbidities, I may give up to 3 months give aspirin, or there are many of those other forms of antithrombotic oral drugs, which is affordable in your healthcare. You can do that.
There's one more question on reinfection. What are the chances of reinfection and then the recovery in these patients? And of course, how would you manage them? Would you give them Remdesivir, or is there anything else?
Yeah. So this reinfection has become a new topic of matter now. So reports are coming up across the globe. China initially said, Hong Kong said, United States. So we have seen in India as well as in our own clinic. So I've seen patients who have been infected and diagnosed in March, April, May. Then subsequently, they completely recovered, and even PCR became negative. Now again coming back with new infections, again with symptoms, and again with the PCR positive. So I think these are the patients you need to treat the same way how you treat the initial case. If they qualify for moderate and severe, you may need to give another fresh, because this is another fresh virus. We do not know the same strain or a different strain. So you need to give another treatment. So again, the first episode of Remdesivir, what you give, it took care of that episode of the virus. It's not like HIV where the virus persists lifelong. It's been there, it's got rid of it, either by the antiviral drug or by the own immune system. So again, when you have another infection, you need to treat the same way. Again, to the sub-question on whether the severity will be very severe. So we need to wait for it. So only thing is, as a clinician, what I see is someone who has been infected with COVID, and they go through a lot of biochemical abnormalities as well as hematological abnormalities, particularly on the lymphocytes. They have lymphopenia. So that means they have low immune system. So again, if they have another episode, probably can further weaken the system. They are prone to develop so many other, infections around them. Similar like in HIV, when the CD4 cells goes down. And also, it produces a lot of cytokines. In the first episode, if it is upregulates, again in the second episode, it can cause a real storm. So you may have to be closely monitor them and do that. And one other question I think the audience might ask is, someone who has developed an antibody, whether they will get reinfected. Again, we do not know the answer. Again, yesterday, there is a very nice paper being published from UK on a very large number of people where they have done antibody tests, almost like 300,000 individuals, where they have seen fading of the antibody titer. So after 3 months. So that means if they have antibody today, after 3 months, probably this antibody might go away, and probably they may not have sufficient another protective power against another episode of COVID. So again, this is a new disease, new area of science. We need to wait for more data on this. At this time, we better protect ourselves, use appropriate masks, face shields in our hospital.
Thank you. Dr. Muang, a question to you. So what are the current antivirals which are recommended in Myanmar for COVID-19?
Yes, the same. We started to use Remdesivir in Yangon.
Okay.
And one patient in Mandalay. A lot of patients are receiving Remdesivir in Myanmar and Nebiro, and one patient in Mandalay.
So one last question, quite a general one, on vaccines. So Dr. Kumaraswamy, you can give your perspective, and followed by Dr. Muang. When are we actually expecting a vaccine for COVID-19?
So quick answer, I want a vaccine tomorrow to protect ourselves. So as you all know that everyone on the race for vaccine, there are 100 odd different vaccines under development. Almost 12 or 13 different countries are developing different vaccines, starting from United States to India. So there are several vaccines under a phase 1 and phase 2 trial. At least 11 different candidates are on phase 3. And out of those 11, 3 or 4 are very advanced. There is one called this Oxford vaccine, which you might be on the news everywhere. They're in a very advanced state of phase 3, where they have already even released the preliminary results, where they have shown the safety data already, as well as immunogenicity and the antibody response by the host, including in elderly people, which are data they have been released in. So this something might be very prominent. But now we need to know that these individuals have stimulated a host immune response. Whether that immune response is going to protect another new episode of this virus, I think that's the important question. We do not know. That's what all these phase 3 trials, recruiting very large number of volunteers, something like 30,000 people across the globe. Also, there are other vaccines there is one called no.of vaccine, which I am been involved in a phase 3 trial in collaboration with our government. So where these are all promising candidates where we feel there could be one. We need one. So might be more than one, might be 2 or 3. I will not be able to tell whether it will be available this year, but mid of next year probably there could be 2 or 3 candidates. But we can't tell that how far it will be all been effective. It cannot be 100% effective. It could be anything from 50 to 60% effective, where it can stimulate a host immune response and antibodies. And that response might vary from individual to individual. Younger people, it might be good. Elderly people might be less response. People with immunosuppression might be less response. And also, we do not know how long that antibody titer will last to protect against infection. I think these are some of those critical questions should be answered, cannot be answered in one day. Once we need a vaccine, people need to be vaccinated. They need to develop a host immune response. Then following them over a period of time, we'll be able. I think these are the questions can be answered in the next couple of years. And also, I may say that might be too early. If you just give a vaccine, you're not lifelong immune. You may need a booster dose like H1N1. We vaccinate ourselves every year. So similarly, probably you may need is as an ongoing booster shot. We do not know whether you need to give every year or every other year, or every 5 years. I think these are some of the things the science will teach us. So I think one thing is very clear. Now we have entered an era of COVID era, which affects everybody. So you can be a younger child, you can be a 95-year-old. We have right now a 95-year-old in the hospital admitted, never been gone out of the hospital for the last couple of years. Many people in their homes have been negative. We do not know, how that elderly person acquired. So this is something what a virus infects everybody. We need to learn, how to live with this, how to prevent this, how to manage how those being affected. We cannot keep isolating and throw them out everywhere. We need to care them in our community, and also we need to develop this idea of this new normalcy, in our culture, particularly in our hospital. How we can take care of and upgrade our infection control practice and take care of our own colleagues before they become infected or exposed to this virus.
So Dr. Muang, any perspectives about vaccine being available in Myanmar?
There was an agreement between Myanmar government and Indian government and previous a couple of weeks. So they agreed to share the vaccine. And I think India is developing vaccine. So I must say that after 3 or 6 months after availability in India.
We will give you, definitely, we'll donate vaccine.
Sure. So before we end the session, any final message from you, Dr. Kumaraswamy and Dr. Muang? Final message for our audience.
I think what I learned in managing these patients is it cannot be managed by one particular doctor, like infectious disease or internist. We need a consortium. We need a critical care specialist. We need an endocrinologist. We need a diabetologist, cardiologist, nephrologist, internist. We need dedicated nursing team. So our hospital, the COVID center, literally run by nurses. Doctors go just set up the protocol and do that. It's run by dedicated nurses. I think we need to set up a team purely dedicated, purely knowledgeable, keep upgrading, their knowledge, and with the, state-of-the-art infection control practice. I think that's something where we need to, do that. But also, having said this, we cannot ignore the non-COVID activities. So when we did this, many of those non-COVID patients, they are not cared. In fact, diabetic people, they became worse. HIV-infected people, their continuum of antiretroviral care were distorted. Hypertension couldn't be done. People who have toothache, they lived with their pain, for years. There are no dentists available. People who had eye problem, they are not cared. So I think, we need to run those non-COVID programs. That is something is very important. I think these lessons, what we learned in the last 7-8 months, really help us how we should care COVID. And on the other hand, we should not ignore non-COVID. And but on the other hand, how these populations should not mix each other and infection control practice to be developed. And also there are newer therapies coming up. Don't just have a negative impact on some of those clinical trials show some drugs are not working. So again, we need to have an optimistic that there will be a therapy, newer therapy, combination therapy, all will be available, anytime soon. We will conquer this virus.
Thank you. So Dr. Mull, final message. Yeah.
Because of the endemic nature of the disease, we now understand the more importance of prevention than treatment these days. I think we need to emphasize on prevention of diseases in Myanmar. Thank you very much.
Thank you. So that brings us to the end of this session. So I'd like to thank Dr. Kumaraswamy for giving us, the complete details about COVID, the way it has evolved to the current situation as we see it, and Dr. Muang for giving the perspectives and insights from Myanmar. It's been quite a challenging time, and right from the beginning, science is evolving, evidence is, changing day by day. When we look at Remdesivir, right from, the early trials, from compassionate use to emergency use authorization in US, then it moved from severe patients to, again, moderate. And today, when we look at it, if I look at the regulatory approval of Remdesivir, like in October, very recently, the US FDA has given an approval for all hospitalized patients of COVID-19. So we are evolving, we are changing, and we have started living with Corona right now. And we are very optimistic that we will fight this disease. And we'd like to thank all the, the frontline workers who are making extra effort in trying to manage this disease. So on that note, on a very optimistic note, we do understand that Myanmar is going through the second wave right now. Hopefully that things will be under control. And with the new, year coming up, hopefully we'll coming up with some new therapies as well as the vaccine, which is going to help us combat COVID. Yeah. Thank you very much.
Bye-bye. Thank you. Stay safe.